Welcome to AETCM, the emergency medicine channel. Today we are going to discuss about an elderly female who presented to ER with reduced sensorium. Shall we start? 68-year-old female presented to ER with the complaints of reduced sensorium. So on arrival, we started with the primary service. Airway was patent, there were no secretions. Regarding the breathing, air entry bilaterally equal, respiratory rate was 20 breaths per minute and saturation was 95% on room airs. Next, coming to the circulation, the pulse rate was 78 per minute and BP was 140/80. We connected her to the cardiac monitor and we had put 2 IV access lines and we had taken the bloods for further lab investigations. Next, coming to the GCS, patient has a GCS of E3, V4, M6.
7 plus 13.
13. The problem in the assessing the GCS was patient was not oriented, but like she was not being vocalizing her things, but she was watching out, looking all over and moving all the 4 limbs and following some partial commands like lifting the hand, but she is not able to tell her name herself. So we had given the GCS of E3, V4, M6. Pupils were sluggish and 2.5 mm, which are equally and bilaterally reacting. There was no anisocoria seen. Next, regarding the exposure, temperature of the patient was 97.8 degree Fahrenheit, not febrile. So we went, as the patient was disoriented on arrival, we went ahead with the first investigation of GRBS.
Not febrile means what?
She's febrile, sorry. Yeah. She's not febrile.
He told not febrile.
Sorry. We taken the GRBS, initial GRBS. Initial GRBS was 126 mg per dl. Then we went ahead with the ABG. In the ABG, there was no acid-base disorder, but there was hyponatremia. Sodium was of 110. So ascertaining to the symptomatology that the patient is disoriented and the sodium ABG value was 110, we had first clinical indication that the patient was having hyponatremia. That is the reason she was in confusion state. So at this point of time, we had sent for a sodium workup, which is sending for serum osmolality, urine sodium and urine osmolality. Next, coming to the secondary survey, patient...
What is the importance of all these tests in hyponatremia management?
So hyponatremia management, first grading the hyponatremia depending upon the symptoms. Next, finding out the causation of the hyponatremia is to be done. In the causation, first with the parameters seeing the serum osmolality. Depending on the serum osmolality, it can be hyperosmolar, normotonic, hypertonic, normotomic and hypertonic. So in...
What is your opinion? Depending on the osmolality, how many types of hyponatremia?
Three types.
280 hypotonic.
3 types.
320 isotonic, more than 320 hypertonic.
Clinically, how many types are there?
Clinically 2, on the lab wise, parametrical wise 3 types. Yes, sir.
Clinically only 2 are there.
True hyponatremia and pseudo hyponatremia.
All depends on your values only, but
Yes.
Clinically there are only 2. Suppose you had given a mannitol to a patient, it will become pseudo-hyponatremia. If the patient is having high blood sugar, pseudo-hyponatremia. All other hyponatremias are hyponatremias. And next thing is you have to see whether the patient is symptomatic or not. Then the next classification comes. Third one only, depending on the fluid.
Yes.
Hypervolemia.
Next, we have to assess the volume status. It can be hypovolemic, euvolemic, or hypervolemic. Hypovolemic can be causes by renal cause, also as non-renal cause. Renal causes examples are when we have given diuretics like thiazides, or patient having Addison's disease or cerebral salt wasting. These all cause renal loss of sodium. Whereas in non-renal cause, GI losses like vomiting, diarrhea, burns patients. These are non-renal causes. In both this is hypovolemic hyponatremia. In this, we have to check for the urine sodium. The urine sodium greater than 20 indicates it's a renal cause. Urine sodium less than 20 indicates it is a non-renal cause. In either of this hypovolemic hyponatremia, treatment would be using the normal isotonic saline.
What is this renal? He is telling about renal sodium less than 20, more than 20. What did you understand?
Urinary.
What is your
Hyponatremia with renal loss more than 40 suspected ADHD.
less than 20?
Less than 20 is extrarenal causes like vomiting.
Suppose patient has not taken any salt. You are not losing anything.
Chronic.
What will happen to urine sodium?
Yes.
That is the thing. That is a basic physiology. When you have a hyponatremia, if your kidneys are normal, kidney will not lose any sodium. That's all. Suppose you have not taken any sodium for last 3-4 days or elderly individual, he'll go to hyponatremia, but he's not losing anything. Not neither losing through kidney nor losing through any other route. He is having a depletion hyponatremia. So suppose in that patient is not taking any salt, he has gone to hyponatremia, and urine sodium is high, then the diagnosis is entirely different. If urine sodium is less, means he is not losing salt through kidney, and kidney is trying to protect your body. So that is a normal physiology.
Next, in the euvolumic hyponatremia, when the volume is normal, the most common causes would be an SIADH here, and other common causes is hypothyroidism, psychogenic
What is the
polyps.
most common cause for increased renal output of sodium in your practice? I am not talking about
diuretics.
in your practice. You are seeing in ICU so many conditions.
UTI.
So that is not given actually in books. The most common cause for renal loss of sodium is urinary tract infection. So elderly individual admitted with hyponatremia, urinary tract infection, you can see urinary loss is there. That is neither due to SIADH nor due to hypothyroidism. It's all due to a kidney injury or the renal tract injury. Okay, that is the most common cause. But like you told, other ICUs, it can be due to diuretics. Okay. Then SIADH. SIADH is not at all very common in routine clinical practice. We may be seeing because it's a tertiary, being a tertiary care center, we are getting. But otherwise, the most common cause is urinary tract infection. Okay, and like you told, it is diuretic.
Next, in hypervolemic hyponatremia, basically it's a dilutional kind of hyponatremia because of renal failure, liver failure, heart failure. In that kind of patients, the urinary sodium, if it is less than 20, it can be CHF cirrhosis dissolve. If it's greater than 20, it can be CKD, like a renal failure. So treatment here would be usually fluid restriction and giving diuretics, or the third line of agent can be using vasopressin antagonist like tolvaptan.
Okay.
This is the approach and classification of hyponatremia. But regarding the treatment guidelines, treatment either we have to divide into symptomatic and asymptomatic. Where symptomatic is defined if the patient is having like a seizures, coma, in that kind of acute presentation.
What is the common presentation you see in your
Confusion.
Confusion. Altered behavior.
Altered behavior. That is moderate. Severe would be coma and seizure.
First is weakness, then it is moderate is confusion, third one is coma seizures. Okay.
In case of coma seizures, then we need to be giving an acute correction of sodium by giving 150 ml of 3% saline over 30 minutes. For every episode it happens, maximum to 3 times we can give such way. But our treatment goals should be like 4 to 6 milliequivalents per day in moderate with mild symptoms.
4 to
6 milliequivalents for moderate. If it is severe, 8 to 10. 4 to 6 milliequivalents per day.
How do you do that? 4 to 6 milliequivalents per day. You want to give 4 to 6 milliequivalents per day as an infusion or the correction?
The total 24-hour correction.
Correction. You want to increase by, the lab value should raise by
4 to 6
milliequivalents.
But if it is a severe case where there is seizure or coma, then you can go to 8 to 10 milliequivalents per day over the 24 hours.
Okay. What are the side effects of 3% saline infusion?
Hypertonic.
Intravascular volume increase. So cardiac failure.
That is the most dangerous problem. Cardiac failure patients, when you are giving this, it can produce severe cardiac failure. Pertaining to this hyponatremia as such, what is the most important side effect? Osmotic demyelination syndrome. So we have to be very careful. Sometimes patient can go to osmotic demyelination syndrome even when you are giving a normal dose. That is a problem. So it is already, like, it is well explained that it is not the time of the correction, like duration of the correction, it is not the dose of the 3% saline. Whatever may be the time or duration or dose, patient can go to osmotic demyelination. So we have to be very careful.
Okay. Regarding the osmotic demyelination syndrome, it is like sudden or overly rapid correction of the chronic hyponatremia can lead to osmotic demyelination syndrome. Previously, it is called a central pontine myelinosis. And here it is more dangerous if the patient is underlying condition of malnourished, alcoholic or failure patients. In these cases of patients, it's more commonly seen.
What are the clinical features of osmotic demyelination syndrome?
Basically, onset would be delayed after 2 to 6 days of the correction. appears, and there will be dysarthria, dysphagia, next spastic quadriparesis, locked in kind of syndrome, coma can be worsening to coma and
Extrapontine?
seizures. Suprabulbar,
Extrapontine.
pseudobulbar palsy.
Extrapontine.
Extrapontine.
Pontine means cerebellum. Sorry, cerebrum is involved.
Brainstem.
Pontine is brainstem.
Okay.
Extrapontine means patient will be confusion, altered behavior, seizure, all these things. Pontine means like you told, locked in like syndrome, like feature.
So regarding the rate of correction, the ideal choice would be if it's a very chronic patient and with high risk, then 4 to 6 would be the range we have to correct per day or 24 hours. If it is an acute, within 48 hours as we defined acute hyponatremia, then we can correct with a fast correction. And if it is a chronic, it is greater than 48, then highest like target should be 8 milliequivalents per day or 24 hours. In some cases, depending on the requirement, till 10 milliequivalents.
How do you calculate the deficiency?
You calculate the deficiency by the 0.65 into body weight into the 8 milliequivalents. That's the sodium correction which is targeting per day. For males, for females, 0.6.
0.6. There is a body percentage of body water
weight. That should. Yes, regarding this patient, initially when we got the lab values, the patient's serum sodium was 110 and serum osmolality was 247.
Today's sodium. What is the target now? He has told so many things. What should be the target tomorrow by this time? Today we are starting 3%. He is going to start 3% saline for this patient today, now, 2 o'clock. Tomorrow by 2 o'clock, what should be the sodium? 116. So that more than that, if you are correcting, let's say every 6 hours we have to check the sodium. If it is getting corrected more than that, we have to be very careful. We have to stop the infusion, wait for next 24 hours to restart.
Yes.
Okay. Without monitoring patient, you should never give sodium infusion.
The serum sodium was 110. Serum osmolality was 247. That was hypovolemic, sir. Hypotonic, that is true hyponatremia. And then urinary sodium was, urinary osmolality was 562.
That is high.
Yes, sir, it's fine. And urine sodium was 200, sir, which is elevated. So the renal losses was present with the true hyponatremia.
So what will you suspect? What is your first suspicion? What is your first suspicion? Patient with altered behavior. Patient is having what else? Hypothyroidism?
No. Patient right now, like comorbidities wise, only COPD was.
COPD is patient's sodium is low. Urinary sodium is 200. Osmolality of urine is very high. What is the first difference? SAIDH is the first differential. SAIDH has. So that is secondary cause for SAIDH. SAIDH is the first differential. Patient is altered behavior. Patient can have encephalitis, meningitis. That itself can produce SAIDH. What is the difference between SAIDH and cerebral salt wasting syndrome? You have a patient who is having encephalitis, meningitis here. She is having SAIDH-like features. What is the difference between cerebral salt wasting syndrome and SAIDH?
In SAIDH, water is retained.
Water and salt. Only salt.
Salt is getting lost.
Okay, so there patient is dehydrated too.
So here serum osmolality was also 247. So there is a point of cerebral salt wasting.
But patient is not dehydrated, no?
Yes, sir.
Patient is dehydrated means then you have to suspect that. Otherwise, it is like it can be SAIDH only. There is no hypothyroidism, there is no kidney failure, there is no renal damage.
So in this case, we started with 3% saline. As the patient was looking like an SAIDH, initially fluid restriction was advised and followed by 3% saline correction was added because serum sodium was 110, sir. After 24 hours of correction, during the 24-hour correction, after 6 hours, serum sodium became 120 from 110, 10 milliequivalents it rose. So immediately we stopped with the 3% saline and started with the free water correction. After next 6 hours, it became 116 and finally finally by 24 hours it has become 114. So 4 milliequivalents got corrected in the first 24 hours. But regarding the sensorium wise, patient was still moving her forelimbs, but she was not able to vocalize any sound or anything, but just only incomprehensible sounds were there. But on calling her name, she was able to open her eyes and look at the person. GCS slight improvement, but not completely oriented as of now. So we went ahead with an neuroimaging to see if there is any pathology causing her aphasia-like symptoms. When we did a neuroimaging, we found that there is a bilateral temporal lobe. There were changes, like lesion-like changes. So considering it to be a stroke-like changes, initially we started with the dual antiplatelets and loaded her with dual antiplatelets and statins. Further, as a progression of the disease, as there's no improvement, we went ahead with and her CRP was also elevated, sir, 128. So to rule out the infective pathology, we went ahead with an LP. In LP,
what is this temporal lobe? He is telling bilateral temporal lobe involvement. What are the conditions you get temporal lobe encephalitis? Herpes is the most common thing. Then second one is autoimmune. There are two important conditions. There are a lot of other conditions also can have similar features, but in our setup, herpes is the first one. Second one is autoimmune encephalitis when the patient is elderly and a lot of comorbidities are there.
Yes. Regarding the CSF study, the CSF glucose was 60, which was low as less than half as compared to a normal GRBS of 189.
So bacteria is most important, bacteria or tuberculosis?
Next, CSF protein was 245, which was on the higher range.
That means there is an inflammation. Yes. Bacterial, viral, tuberculosis and autoimmune. All this one will be elevated.
Regarding the cells, there were 655 cells, but the LP was traumatic, so there were RBC in the background and 85% were segmented.
Is it traumatic or hemorrhagic? How do you know? Is it? He is telling it is traumatic. How do you know that it is traumatic or hemorrhagic?
Most ones will be bloodstained after second, third.
Traumatic means initially it will be bloodstained, afterwards it will get clear. Or you can just keep the sample for some time. So if it is traumatic, that blood will become clotted after some time. If hemorrhagic means it will be continuously blood only.
So this was traumatic. Initial only there was blood and finally we had a clear fluid. There are 655 cells, out of which 85 were segmented and 15 were mononuclear. Depending on the picture, it was looking more like bacteria or tubercular because there were segmented cells along with...
Can you get neutrophils in tuberculosis?
Initial phase of the tuberculosis, there will be neutrophil predominant.
Phase of tuberculosis, it will be neutrophils. Like that, chronic phase of bacteria, it will be lymphocytic. So it will be very difficult to make a diagnosis.
But we can consider it to be a bacterial or tubercular rather than a viral fungal picture.
Viral will be ruled out.
Yes, because of the increased proteins and low glucose. Even fungal also highly unlikely in this scenario. So in view of the present CSF findings, we went ahead and started with an empirical therapy of meningitis. As she is an elderly, more than 50-year-old elderly person, we had you even cover listeria. So we started ceftriaxone, which is 2 gram.
Listeria coverage is which?
Ampicillin, like empirical treatment. Ampicillin. Ceftriaxone 2 gram BD. Next, acyclovir 10 mg per kg body weight TID dose we have to give. And next, ampicillin we give.
What are the adverse effects of these drugs? Ampicillin, ceftriaxone, one group. What is that other drug you gave?
Ampicillin.
Acyclovir, another drug. What are the adverse effects?
Adverse
effects. Know the adverse effects.
Acyclovir usually causes pre-renal AKI kind of thing, so there will be dehydration. We need to hydrate the patient.
Hydrate the patient well when you are giving
acyclovir.
But other two drugs?
Regarding the ceftriaxone,
ampicillin, very high dose, ceftriaxone, very high dose in meningitis. It is a drug of choice. That is, I agree with that.
First thing is anaphylaxis, which will...
It has not occurred, no?
Okay, sir. Second thing is ceftriaxone can cause seizures potentially.
Then can you rupture of the...
That is a capsulated organism, it can produce. Okay. What is the other side effect, most important side effect in this? Both are having high seizure potential. Both the drugs, penicillin and ceftriaxone. Okay. But most of the time it may not come. But if it comes, then you should be you should know how to treat that also. Okay. Very rarely you can get seizures because of penicillin and ceftriaxone. But when we are combining these two drugs in a very high dose, there is a chance. That's all.
Yes. Also, before the initiation of antibiotics, Dexa of 8 mg stat was given in view that it can be bacterial.
That is for what? What is the reason?
Inflammation. Reduce the inflammation side.
That is the answer. You told is correct. But capsulated organism, you are expecting a gram-positive capsulated organism. In that case, you have to give first dose. When will you withdraw that? So continuously you are going to give, or you are going to stop it?
Once we rule out,
LP is done. Peripheral smear, you can find out. You can see whether it is a streptococcus or
Gram
staphylococcus. If it is negative, you can probably stop it, but you have to continue in one more condition.
TB.
What is it? TB. In TB, steroids are indicated in which all conditions?
active phase.
TB.
TB meningitis.
TB meningitis is one.
TB pleural effusion.
Massive pleural effusion, rapidly accumulating pleural effusion pin. Then TB of eye, TB of genital organ, then adrenal failure. These are the common conditions like massive pericarditis. Also, you can give. If you don't give steroids in TB, what will happen? What can happen? What will happen?
Fibrosis.
TB ends up meningitis. What is the complication if you don't give steroid? You are near to the answer. You are not telling. Near to the answer.
IC pressure will increase.
Obstructive hydrocephalus. That is the most important problem. So many patients who are not treated with steroids in tuberculosis, they have gone to obstructive hydrocephalus. That's why we are giving steroid.
Yes, sir.
What she told is correct.
Inflammation.
Fibrin bands, inflammation, sediments, everything, it will produce finally obstruction.
So, as in this case,
You have to use the correct words. In exams, if you don't tell these words, examiner will ask multiple questions.
initially a single dose of dexamethasone was given, followed by empirical antibiotics
Why
was started.
dexamethasone? He is selling dexamethasone. Why? Can
Long
use some other
acting.
steroid. So blood-brain barrier crossing maximum capacity is for dexamethasone. Other drugs also can cross, but this has got maximum penetration power.
And the empirical antibiotics have been started. And during the course of the hospital stay, her cardiac monitor was showing T wave inversion. So we had taken in repeat ECG, 12 lead ECG. In that lateral lead, T inversions were visible.
What are the possibilities for a deeply inverted T wave in this patient?
Deeply inverted, if there is IC pressure, intracerebral pressure increase, there can be a
Cerebral T
waves.
Okay.
And we have repeated cardiac enzymes, and repeat cardiac enzymes, there was serially elevating cardiac enzymes. So repeat echo was done, and there was basal segments, a kinetic movement was seen.
So there is a chance of myocarditis.
And STEMI was diagnosed, and we had to, anyhow, dual antiplatelets were started in view of this stroke. So we continued along with that anticoagulation by heparin, 5000 international units, TID was also continued for the STEMI management.
Okay.
And regarding the CSF study, the specific study, gene expert has been done. Today morning it has come positive. So we had to convert the empirical antibiotics to ATT, isoniazid, rifampicin, pyranezumab and ethambutol. Along with that, even dexamethasone 0.3 to 0.4 mg per kg per day is the...
What are the drugs? TB drugs has got maximum penetration to inflamed meninges.
Isoniazid.
INH. Then? That's all.
I mean, that is a major import.
Entrance recently finished entrance, no? NEET. Le. Learned it. One is INH. That is correct. Second drug. Huh? Rifampicin is not a good. It is a good drug for TB. It is not a good drug to penetrate the inflamed meninges. Pyrazinamide has got one more, like it has got a maximum penetration comparing with other one. Other one is streptomycin. So these three drugs has got maximum penetration to inflamed meninges, but rifampicin has to be given for what?
To prolong, like delayed back.
Slow growers.
Slow growers.
To prevent slow growers. Okay. Slow growing bacteria, TB bacteria. So rifampicin must be there, but if you can add these three drugs, there will be like better penetration to the inflamed meninges. But anyway, we are giving INH and pyrazinamide. Streptomycin normally we don't give, but if you can add that, it will be very good. It is not second line, it is a first line drug. Streptomycin is a first line drug.
So
But we don't use it routinely because it has got lot of side effects. So it has slowly become a second line drug.
in this case, we had hiked up the antibiotics to ATT management along with DEXA as of now. Regarding the other parameters, regarding the cardiac parameters, patient was having NSTEMI, so dual antiplatelets with anticoagulation was the treatment. And regarding the hyponatremia, patient was still having urinary loss with serum sodium
You are
being...
giving warfarin? No.
No, warfarin.
Only
heparin.
heparin.
As of now, 5 day history of heparin.
Okay.
And regarding the hyponatremia management, even tolvaptan was added because of the urinary to reduce the urinary losses.
Okay. So what all things you have to monitor when the patient is on your ATT, tolvaptan,
First thing is to see the LFTs.
LFT. So both the drugs will act on the liver, and liver alteration is the most common thing. Okay. If you are putting the patient on warfarin, then what is the important thing you have to check?
Iron.
We are saying drug interaction. Rifampicin and warfarin will have some drug interaction. So that should be taken care of.
And during the hospital stay, a patient developed an acute onset of GTCS.
Okay.
So during the course of GTCS, first initial agent of benzodiazepine midazolam was given. Patient was given midazolam and patient's GTCS has stopped. Then we have loaded the patient with levetiracetam and continuing the dosage of Levipil.
Can you give phenytoin in this patient?
CSF, we can.
Again, phenytoin also
LFTs will
through
be
liver this one. So that also can alter liver. So better to avoid that type of drugs. So levetiracetam is a better choice. Phenytoin is good, but in this situation, better to avoid that drug because it can produce again liver damage. So levetiracetam, what is the dose?
Levetiracetam loading dose would be around 1500 mg per kg per body weight.
15 mg per
7.
dose. What is the loading dose you give for the patients? 1 gram. 1 gram. That comes around 15 milligram per kg body weight.
Yes. Apart from that, continuing dose of 500 mg BD.
BD or TID?
First we give is BD.
First is TID, then you can reduce the dose.
Okay,
You can reduce to BD, then you can reduce to OD. So first is always TID because you need to cover continuously.
Yes.
Otherwise, during that break, it can the patient can throw seizures. You have to be very careful for that.
So right now the patient is still under the treatment. So.
Okay.
Okay, sir. Fine.
Anything else you want to add
Regarding like a patient initially on arrival, regarding the history was basically patient had been treated for acute exacerbation of COPD, post which she developed this hyponatremia, and also there's a history of...
Tell me something about COPD in female patients.
COPD in female patients cause would be usually the stove, burning wood stove. Like etiology wise, that would be the
very rare possibility. But everybody diagnosed COPD in female patient, not very common. COPD is commonly seen in smokers, but rarely because of some genetical problem. Female patients also can develop COPD, but most of the time it is a clinical diagnosis. They don't do PFT and rule out other causes. Okay.
In this, the history of smoking, like
burning
was there. So and also the patient had history of weight loss. Symptoms like paraneoplastic encephalitis can be has put as a differential initially because of her weight loss and the history of this COPD kind, some lung, but nothing was found.
Okay.
Regarding the paraneoplastic encephalitis diagnostic criteria, it is usually a subacute onset, that is less than 12 weeks of memory loss, psychiatric symptoms, movement disorder or seizures kind of history, with MRI showing mesial temporal hyperintensities. As this patient has also a temporal hyperintensity, this was one of the differential. And CSF will be showing increased protein, oligoclonal bands and lymphocytic pleocytosis. Here lymphocytic, but we had neutrophilic finding.
That is well explained. In acute phase of TB, you get the neutrophils.
Yes. And if we are suspecting for paraneoplastic, then we need to go with a tumor screening of CT, MRI, PET scan, and further ECSF for onconeural antibodies and further kind of things. And treatment wise would be first tumor removal or chemotherapy, and definitely immunotherapy with IVIG, plasma exchange, and some monoclonal antibodies like rituximab.
Okay. Thank you.
Thank you.